All's good.
Wonderful, wonderful. So how have you been doing? Everything's been going well?
Yeah, it's honestly, during the COVID-19, ever since we went into isolation, we've been much busier. Everything's been so incredibly busy.
Oh yeah. I can only imagine, especially you being in the healthcare field. I'm sure that has some sort of impact on that.
Yeah, and honestly, usually the story in most healthcare organizations is that so much of a hospital system's revenue, I mean, most hospitals are not-for-profit organizations. They run on very, very, very tight margins.
Yeah.
And with COVID-19, a lot of the, like elective procedures, people are, right now, people who feel mild symptoms of a heart attack or they're mild symptoms of a stroke, in a lot of cases, they're saying, you know what, no, I'm just going to take some aspirin and wait for it to pass. And so we're seeing in the hospitals people ignoring the signs that would normally send them to the emergency room.
Yeah.
And what's unfortunately, that's leading to a much higher death rate. So if you take the number of like COVID-19 cases, there is we're experiencing in the United States a statistically higher death rate than normal.
Yeah.
Because the healthcare system is getting overwhelmed and people are not going in for the normal care they would that would avoid, terrible problems just around the corner.
They're not taking it very seriously. They may say, okay, a cough is just a cough, or
well, and sometimes it's really hard to tell. You're like, I'm maybe that's, maybe I just had a severe migraine when it was a minor stroke, or maybe I'm just having some heartburn when they just had a small heart attack, which untreated leads to a much worse heart attack down the road. And then the hospitals end up being really financially hurt. So even though the emergency department and the ICUs are incredibly overwhelmed, and they've got tons of cases going through there, other departments in the hospital are very, very quiet. Like, honestly, probably this winter, we're going to see the maternity wards start to really severely quiet down because, we've seen that the pregnancy rate and birth rates are starting to take a nosedive. So there are a lot of things where, for a lot of reasons, most of the hospitals, the business is going down during COVID-19. We're in a weird situation, though, because our ambulatory surgery centers, in most cases, are outside the hospitals. Sometimes they're in a totally separate medical park. Sometimes they're in a medical outbuilding on the hospital campus, or there's always some level of separation. And patients feel a lot safer coming to an ambulatory surgery center to get a procedure done. And in fact, the hospitals, in order to free up critical care beds or to redesignate beds as critical care beds, they're shifting cases out of the hospitals into the ambulatory surgery centers. Kind of fits that criteria of lower acuity cases where they can be discharged the same day. So we've actually
create more space
going up.
It's interesting. And you're in the surgical industry, right? Or could you
Correct.
just
we manage all aspects of ambulatory surgery centers.
Okay.
So, in our facilities, we've got a preoperative area. We've got operating rooms exactly like you would find in a hospital with all the same capabilities. We have a post-anesthesia care area where after you've had your surgery, you come out of anesthesia, we make sure you're stabilized. And then at the end of the day, we stabilize you, your loved one comes, picks you up, and we send you home. We're licensed for 23 and a half hours a day of care. So at most of our facilities, these are things like, it's actually surprising the kind of surgeries you can get and still go home the same day. So, we've done total joint replacements, like a knee replacement. There's a lot of different surgeries, carpal tunnel, plastics, so a whole bunch of different surgeries that can be done in an ambulatory environment.
Interesting. And how do you, okay, so you're on IT projects, you're a project manager, director, or program director per se. So how does that apply to, the surgical center side of things? Like, how do you intertwine those?
So my background, for the last 15 years has been healthcare IT in hospital environments. When I came to ambulatory surgery centers, it was really a different business model. And it took me a little while to learn, because at a hospital, it's kind of a weird thing in this country. It's a business where you really can't control the products that you're delivering.
Hmm.
So because because of the laws we have in this country, if you are sick and you go to the emergency department of a hospital, they're not allowed to turn you away. They're not allowed to say, "I'm
Right.
sorry, you can't pay." So on any given day, a hospital has no idea literally no idea what's going to walk in the door. It could be somebody who has been shot, somebody who's having a severe heart attack, just whatever the case is, they have to kind of be ready for everything. In an ambulatory surgery center, you never ever walk into an ambulatory surgery center and just announce that you're going to have a surgery. It's always a scheduled event. And as a result, because it's a scheduled event and because it's not an emergency, we are able to kind of take a look and see, is this a surgery that makes sense for our surgery center?
Mm-hmm.
And we're able to, we're able to control the ebb and flow of those cases coming into our centers. So from an IT perspective, there were a lot of things that changed. A hospital has to have really high availability 24/7. And so most hospital environments, especially as they have a greater and greater level of IT penetration,
Mm-hmm.
they end up having very, very expensive IT functions because, diminishing returns, in order to getting up to like 2 nines of availability, not that big a deal.
Right.
As you get, 3 nines, 4 nines, 5 nines of availability, you have to start implementing clustered systems, redundant systems, multiple data centers, real time, multi-site availability, really, really intensive disaster recovery plans. In a hospital environment, that is just the price of doing admission. Especially, there's an organization called HIMSS, which
I know that one. Mm-hmm.
so HIMSS has different stages they rate hospitals at. HIMSS stage 7 has the greatest level of integration of all the technology in the hospital system. So the clinical care system, revenue cycle systems, just every aspect of IT is completely integrated under one, intertwined structure. In a HIMSS stage 7 hospital, the availability requirements are ridiculously high because they just start operating a little bit differently. For instance, when I was at Tucson Medical Center, we took it to a HIMSS stage 7 hospital. And I had hired a new administrator, and that administrator came from a different industry and didn't really understand the impact of making a database change in the middle of the day.
Hmm.
And so I'm like, hey, let's go gown up. Let's go observe a surgery. So we gowned up, worked with the OR management, went and observed a surgery. And what was enlightening for that person is, normally there's an anesthesiologist in the operating room, and in a old-fashioned hospital, they're standing in front of the cart that's connected to like the oxygen and the anesthesia that you're breathing in. And it's also monitoring your vital signs and your blood chemistry to make sure, because anesthesia in essence is balancing between not killing you and keeping you asleep.
Right.
It's a very difficult balance. But in a HIMSS stage 7 hospital, that cart is actually kind of pushed to the side because that anesthesiologist is getting a much richer view of data in real time from the electronic medical record system, because that card is actually feeding its real-time data into the EMR, and then the EMR is providing that anesthesiologist with decision support, so that if the blood gas starts going out of spec or the heart rate starts to increase, the EMR is actually going to light up and say, "Hey, anesthesiologist, there's a problem about to happen. You might want to consider injecting this medication. You might want to consider reducing, the body temperature. You might want to consider X, Y, or Z." And so if on the IT side, if there's a data center failure at that moment, patients don't have an Ethernet port. The patient is not literally just going to die because IT went down. Mm-hmm. But the biggest risk is that it will disrupt what's going on in that operating room. It will disrupt
decision making.
Then he's got to push the screens aside. He's got to move the Draeger cart back out in front of him. He's got to reorient himself. And that's the kind of distraction that can create what we call a sentinel event, where in that moment of distraction, maybe a surgeon's like got to do something stupid like miss a sponge as he's sewing you up or something, or or just cut where they're not supposed to cut, or inject something they're not supposed to inject. They're highly trained professionals, but if you go in and you create a big disruption in the operating room, that's when you have accidents. So that is the very riskiest moment in healthcare IT, is if you do something that's creating a distraction during that critical moment of patient care delivery.
So you'd say like more of a, I guess like a risk type of deal where if the data center's down or some of the IT, I guess you could say aspects are down, then it's going to disrupt the surgeon's decision making. So you feel
Correct.
okay.
However, that is in a hospital environment. When I came into ambulatory surgery centers, it really is a different business model because of rules that Health and Human Services has put out and incentives in Medicaid and Medicare for reimbursement, hospitals have adopted electronic medical record systems. Your family physician has also adopted electronic medical record system, because that doctor is incentivized to, he gets higher reimbursement if he has an EMR from the insurance companies and also from Medicaid and Medicare if they accept that payment. So industry-wide, physician offices in that ambulatory environment have EMRs, hospitals have EMRs, surgery centers, because they're kind of a new entity, right now they're in a gap between those two. They actually are not required by anybody to have an EMR.
Interesting.
So 95% of ambulatory surgery centers have no electronic medical record system. They're still on paper charts.
You're joking me.
I'm totally.
Wait, so why is are they planning to transition over, do you feel like, or is it?
The political reality right now is the executive branch right now has a very low regulatory focus. My personal belief is that at some point when there's a change in the executive branch and someone comes in who has a focus on providing a higher level of regulation, somebody puts somebody into Health and Human Services, they're going to take a look and start doing a review of the data that's available. And they're going to see that the insurance companies have been pushing more and more surgeries into ambulatory surgery centers because it's lower cost.
Yeah.
So Blue Cross Blue Shield, Aetna, Cigna, they all, when they're negotiating their contracts with hospital systems, they're saying that, I'm just going to make this up, if there's a specific surgery code for thumb knuckle replacement, that the insurance companies are going to say, right now you're doing 10% of your knuckle replacements in ambulatory surgery centers. We want you to move that up to 50% or 70% because it's going to lower their costs. So at some point, Health and Human Services is going to see that, once upon a time, there were almost no surgeries being done in surgery centers, so not having an EMR wasn't a big deal. But they're going to see now a lot of surgeries are being done in surgery centers.
Right.
Have a gap in data. There's no, in general, most surgery centers, because they're paper charts and they're not searchable,
I can't believe that.
Unless you put out an extreme amount of effort to have somebody, build, make a paper chart into a database. They can't do the same type of clinical analysis you can do in a hospital environment.
Interesting.
So it's kind of a lag in the laws right now. So right now in all of our surgery centers, just like everybody else, we are paper records. So in the morning when the staff comes in, if there's let's say there's 20 surgeries scheduled that day, they're going to print out. We have printers that just start humming all morning, so they're going to print out these packs of charts that are barcoded and connected to your patient account. And on those charts, pen and ink all day long, they're going to be writing down your vital signs. They're going to be taking notes about what happened during the surgery. And at the end of the day, they scan those paper charts in, and that goes into our patient accounting system. But we don't have the same level of HIPAA data that a hospital does. We don't have the same level of clinical data to do research and reporting on. It's very transactional.
Yeah, that definitely sounds like an industry challenge. And Jon, what I want to ask you also is from more of a departmental challenge, what are some of those challenges that you face? What are
From an
some?
IT department. So my area of responsibility, my title is director of IT,
Mhm.
just by nature of our company, but I'm essentially the CIO. I'm in charge of all aspects of IT, information security. Uh, the challenge there really, a lot of our challenges are built around cost structures, because you know IT in most healthcare systems, although they try to save money, uh, I can tell you IT in hospital systems spends a lot more per, pick your business metric, per patient, per facility, per square foot. The IT spending in hospitals is way, way higher. Because of the transactional nature of surgery centers, they're very, very focused on, identifying cost per case, and making sure that, because in general, most surgery centers are for-profit entities. So they're very,
Mhm.
very focused on making sure that they keep a close eye on, you know, labor per surgery, cost of supplies per surgery, cost of all the back end infrastructure, which includes IT. So we're super, super cost conscious. We're very, very focused on making sure that everything is very secure, because as a surgery center management company,
Mhm.
if we were to have some type of healthcare breach, it would be catastrophic to our business model.
Mm.
Because at that point, our strategic partners, that like Banner Healthcare, they would say, not only do we want you to stop building new surgery, but as soon as our contract is up, you're out of here. Or worse, they could just say, like, we're going to end this today. If
Okay.
we don't have surgery centers to manage, we are all out of business.
Hmm. So you would say more so like the security and then the management of costs are some of your more bigger challenges as it from a departmental standpoint.
Correct. Those are our two biggest challenges. Like right now for 350 staff, we have 12 active locations right now plus headquarters. I have a outsourced, our IT is split into two tiers. Tier one is an outsourced help desk out of Dallas, Texas, that specializes in healthcare IT. They do a great job. And I pay less than I would for a single help desk staff person for that help desk function. And then tier two are all the rest of my team falls into tier two. And right now I have four operations administrators and myself in tier two for 350, like I said, for 350 staff, and 12 active locations in 2 states, plus a huge number of development tasks. So in order to
Wow.
be that crazy, crazy lean,
Mm.
we are constantly looking at how can we automate things. How, do we really need this tool? Is this really necessary? How can we adjust costs? How can we make this easier to manage? How can we empower users to fix their own issues?
Mm.
So again, everything is focused around cost, customer service, and security. Those are
Cost, customer service,
probably our three
security.
biggest metrics.
Wow. Interesting. So another question I have is from an industry standpoint, what do you foresee, or if you do foresee anything as being future challenges? Do you feel like, yeah.
I, so in the healthcare industry in general, I feel strongly that it's been consolidating, and I think that that's going to continue, because just economies of scale, your negotiating power as a single hospital is, against a system that has like 25 to 50 hospitals.
Mhm.
It's night and day different. Your supply costs are going to be much, much higher. And again, with margins so thin in not-for-profit healthcare, what we see all the time, especially with rural healthcare systems, but also smaller ones, they just reach a tipping point, and once they hit that tipping point, the losses become unbelievably high, and very quickly they get to the point where state healthcare authorities come in and they say, you've fallen below your capital set aside requirements, and they will actually start to broker and say, hey, another healthcare system needs to come in and buy you out.
Mm.
So the largest healthcare systems like HCA, Tenet, Dignity, these organizations are going to keep swallowing their competitors, and eventually, what I foresee is we're going to have a relatively small number of very, very huge systems that are going to just become more and more cost efficient because there's a huge amount of waste in healthcare IT right now.
Mm-hmm.
Uh, as far as ambulatory surgery centers, we see the same thing. We lag the rest of the healthcare industry in this level of consolidation. There are a few really, really extremely large national healthcare ambulatory surgery center management systems, but the vast majority of surgery centers are owned by a small collective of physicians.
Right.
Like 5 or 10 physicians get together, they pool their money. A lot of times they build a surgery center that's in the same building as their doctor's office. So,
Mm.
on this side of the building is where you have your appointment. On that side of the building, they've built a couple of ORs, but you know those facilities are very problematic from a business perspective because they don't, from a supply perspective, they're not able to negotiate. You know,
Right.
they list
They're
pricing.
not big enough.
Yeah, they're not big enough. They don't have professional management because the management of that surgery center is left to whichever doctor has more of a belief that they understand how to run a business. So they lack professional management. Just in every aspect of scaling, they lack. And so what we see happening slowly is, we see this ourselves with our company. We go to these, physician groups, and we say, here's what an average Atlas Surgery Center is able to do. Cost per case, volume, our development capabilities. We talk to them about the development, and very often the physician groups say, instead of running this ourselves, it does make sense for us to sell our interest to you, have you manage the surgery centers, and we will recognize a lot more revenue because of all those efficiencies we bring to the table.
Interesting.
So we believe that more and more there's going to be, there's just going to be probably for the next 5 to 10 years, just a lot of consolidation in the surgery center space for those reasons.
Oh, wow. It's almost like this is just like a brand new industry, and you don't exactly know what's going to happen per se.
To a certain extent, it was really overlooked for a long time, and finally, because of things like high deductible insurance plans and the cost of healthcare insurance becoming so incredibly high, the insurance companies are becoming more and more motivated than they used to be to reduce costs.
Mm-hmm.
And that's why they really are, for the first time, I would say within the last 5 years, they've started applying a lot more pressure to hospital systems to start reducing their costs. And they become a lot more involved, coming in and saying, hey, before we negotiate these contracts, you need to tell us what, they'll provide like a list of, a couple hundred, procedure codes, and say, you need to tell us what the cost of all these surgeries are for you internally. In the same way that Walmart will go to a manufacturer and say, hey, we need to understand internally what your manufacturing costs are because we're going to help you become more efficient. Because starting next year, we're not going to pay you, X for your product. We're going to pay you X minus 20% for your product. So we want to help you become more efficient. Insurance companies are starting to do the same things with healthcare systems, where they're saying, again, you need to move more surgeries out of the hospital into these surgery centers, because a hospital has, they have a pharmacy, they have a police force, they have a cafeteria, they have all these. They're like little tiny cities in many cases, and lots of expense and overhead. Surgery centers, we just don't have that.
Yeah.
We're much, much, much leaner.
Much leaner, right.
Just as safe, the same regulations apply to us. We just don't, because we're hyper-focused on just that lower acuity surgery and nothing else, we're able to just come in at a radically lower case cost.
Oh, wow. That's very interesting.
So we see more of that. The other phenomenon we've seen is lots of large healthcare systems. They started hospital outpatient departments and surgery centers, but they were running them at a loss. It was almost like a loss leader, and they were doing things like when they negotiated with insurance with suppliers for healthcare products, they were saying, okay, if you're, I'm just going to make up a random example here, but let's say, surgical gauze packs that are often used in surgeries. They would say, okay, for our surgery centers, we will give you a much higher margin so you can mark profit on the sales to the surgery centers if you give us a greater discount in our in-hospital operating room purchases and so on. So they were doing lots of things like that. They were doing things to, support the surgeons if they had affiliated surgeons who said, I don't want to have to go into the hospital to do surgeries. I'd rather do it at this local surgery center. For lots of different reasons, they had surgery centers that were being run at a loss. And again, now that and that was okay when they had low volumes, but now that the insurance companies are coming to them and saying, you have to move all these surgeries in the surgery center, and the hospital system is trying to save money, and they're being forced to move cases into a place that's losing money with every surgery they do. Now suddenly they're in a position where they're like, holy cow, we have to find a way of making these profitable.
Mm.
And in many cases, the surgery centers are being run like little tiny hospitals with the same cost structures.
Right.
And again, that's where we've been able to come in and identify a huge number of efficiencies, change the cost structure, and we've been very successful at flipping surgery centers from being something that loses money into something that's highly profitable.
To something, okay.
And to be honest, that is a great thing, because not only does it help the investors in that surgery center, which often are the healthcare company, but also it has the effect of lowering the potential cost of doing a surgery.
Yeah.
If you're in a situation where you have a high deductible insurance plan, you can go to a hospital and you're going to end up paying that entire $8,000 deductible, or you might be able to go to a surgery center and pay a couple $1,000. Depending on the surgery. I mean, there's such a wide range of surgeries. But there are many cases where, somebody who has to pay cash on the barrelhead, it's possible in a surgery center and financially impossible to go to a hospital for that same surgery.
Oh, wow. I never knew that there was that big of a difference between a surgery center and then a hospital as far as the cost structure goes. That's very, that changes the ball game.
The cost structure and the reimbursement for medical conditions and hospitals is blindingly complex, because if you have a hospital in your hometown, that hospital, they don't have like one pricing schedule. It's not like a retail business where they have one price for everything they sell or every service they provide. Instead, they have radically different price schedules depending on who it is who's paying the bill. So for Aetna, they have one. For Cigna, they've negotiated a different one. For Blue Cross Blue Shield, that's a different one. And also remember, insurance companies can't cross state lines. So if that hospital system has hospitals in Arizona, New Mexico, and Texas, it's dealing with 3 different insurance. So like Blue Cross Blue Shield is not one company from a state insurance perspective. It is Blue Cross Blue Shield of Texas, Blue Cross
that is complex.
Blue Cross Blue Shield of Arizona, and they have 3 different negotiated price structures for hundreds or thousands of different procedures that they have. They also have different price structures. I mean, Medicaid and Medicare have fixed price structures. The VA has a fixed price structure, so they just come in and say, this is what we will pay for these surgeries, take it or leave it. And then healthcare systems also will have a separate price structure